when and how to, yeah, that's good, when and how to do it. And before we start out with the trochleoplasty part, I would like to speak a little bit about the evaluation of trochlear dysplasia, because this is why we do trochleoplasties. That is due to trochlear dysplasia, and trochlear dysplasia is the most common predisposing factor for patellar instability. And a new study based on cadavers has demonstrated that severe trochlear dysplasia is seen in approximately 5% of the population. That's quite a lot. And many of these patients will not have any symptoms at all. And you have to be aware of that. They will not dislocate, they will not have any pain, they will just live with it. And then sometimes things occur, they get a dislocation, they get pain, and so it is. However, trochlear dysplasia is in very, very mild cases is seen up to 18% of the population. So those people with just mild or moderate trochlear dysplasia, they are more close to normal than to real dysplasia. That's of importance. Here are some of the characteristics of trochlear dysplasia. First of all is decreased lateral trochlear slope. I mean, this is the support for the patella. If the support is reduced, this can result in a patellar dislocation. Then there's a decreased trochlear depth, and most importantly, in many cases, there will be a medialized trochlear groove. I will come back to that. And an elevated trochlear floor, what we call a ventral prominence. You can see it on the picture on the right above. This is the ventral prominence. The ventral prominence is the same as the trochlear bump. However, the trochlear bump is on bone. The ventral prominence is on cartilage. And another things that can characterize trochlear dysplasia is hypoplasia of the medial part of the trochlea. The trochlear depth can be measured this way. This is the Escala method, and it's you make the posterior femorocondylar line and make lines parallel to this. Normally, if we measure on cartilage, and I think we should measure on cartilage because it's an articulation with cartilage, and in this part of the knee, there will often be what we call bone cartilage mismatch. And you see it on this picture here. You see there is very low height of cartilage. So if you just do a CT or X-ray, you will miss what is really going on because there is this mismatch between the bone and the cartilage. But normally it's 4.9 millimeter. Then there's a facet asymmetry, meaning that the medial facet tends to be smaller than the lateral facet. And if it's below 36%, you will say this indicates trochlear dysplasia. And this is important in respect to the tibio-tubercle trochlear groove distance, a measure that is often talked about when we talk about patellar instability. And for me, the TTG is in most cases due to either a medialized trochlear groove or an external torsion of the tibia. The isolated lateralized tibio-tubercle is quite rare. So for the definition of trochlear dysplasia, there are a lot of classifications, all you see here. They are all based upon subjective issues, just like ice skating. And this is not very good when we are dealing with science, because if we're gonna do things right, we're gonna measure. And the de Jour classification, the one from David de Jour, that is the most popular, the 4-type classification, this is not reproducible. And that's a big problem. I mean, it's very good to see what is really going on. I mean, with the trochlear spur, the double contour, the crossing sign, and the cliff sign, and so on. It's interesting, but it's not very good to evaluate trochlear dysplasia. There are these 11 studies out saying that it's not reproducible. However, if you do like Lipak did together with David de Jour, make it to a binary classification with either high or low trochlear dysplasia, it's fairly or good reproducible. This study was a biomechanics study. What they did was they took knees with either type A, B, C, or D trochlear dysplasia on CT scan, and then they made some plastic models looking like those. And then they tested the contact pressure and the lateral stability. And interestingly, what they found was that if there was a trochlear bump or spur, like in the B and D trochlear dysplasia, there was a higher contact pressure compared to A and C. However, in respect to instability, there was no difference between A, B, C, and D. So you can say de Jour classification is good for when we're talking about pain issues, but not in instability issues. And that is normally why we do trochleoplasty studies, for instability. So I very much prefer measurable parameters, and those 4 I mentioned here are those I like most. And a computer model study has also demonstrated that those 4s are of huge importance, and that's the lateral trochlear inclination angle with the new 2-image technique. I will come back to that. The trochlear depth, the trochlear asymmetry, and the beaded anterior-posterior measure combined, divided with the width of the knee, and I will also show you that later. Okay, but why not just do an MPFL reconstruction? I mean, many surgeons say, those trochlear dysplasia, it's not of importance. We just do an MPFL reconstruction. And basically, we don't know this for sure, but there are papers out there saying that MPFL reconstruction are not always enough. Either they will redislocate or they will have some pain issues. Balcerek, he did this review and found that there was a lower redislocation rate if you did trochleoplasty compared to MPFL reconstruction. And Zhao, he found that if there was a positive J sign, and a J sign, it can be seen in trochlear dysplasia, they tend to have redislocation. So the medial ligament couldn't stand the forces and therefore ruptured. If we look at the papers focusing failures after MPFL reconstruction, they say that in about 50% of the cases, it's due to trochlear dysplasia. The other important factor is wrong femoral attachment site, but that's another thing. And now for the arthroscopic trochleoplasty. I mean, it's 14 years out since I started out doing the arthroscopic trochleoplasty, and I would like to share some of the experience with this. The technique has been published in several papers and 4 book chapters. Those papers can be found on my webpage, so you can download it from there. The book chapters, they are not to be downloaded. Then you have to buy the book, I'm sad to say. However, the videos with this technique can be found on these web pages, Artrex, Bumedi, YouTube, and my own web page will there will also be linked to these videos. So this is a video of a procedure. You see this patella is quite unstable. I start with a standard arthroscopy. You see the dysplasia, and I will put in the suprapatellar portal. I start with a needle and then a switching stick, and I change my scope to look from superior, and there you see the dysplastic trochlea. You see a subluxated patella, and I will find the right spot for my next working portal. I use a needle and then I place the portal, and through this portal, most of the surgery is done. I start out with a radio frequency device to take away the synovia above the cartilage, and then I will be able to shave later. Here you see the trochlear bump. I come in with my shaver and I try to make a cleavage between the bone and the cartilage. Normally it's not as difficult as you might think it is. It's actually quite easy. And then I just go deeper and deeper and try to avoid bleeding, because if there's no pressure in the knee, it starts to bleed. I don't use a tourniquet. And here you see a lambot or osteotome, because you want to keep the bone lateral, because this is what is going to make the lateral slope. So I don't take any bone away laterally, or at least as little as possible, and I start to make the groove and take away the trochlear bump, and then I use the chisel again, and so I just shift between the shaver and my osteotome or chisel, and start to reshape the groove. Then in order to have a good lateral slope, I use this power rasper. It's quite good to smoothen this. And I also use it for the rear side of the cartilage flake, because the cartilage flake, it needs to be plastic. And then you perhaps say, can it then heal back? Yes, it can. I've never seen any cases where it didn't heal. And you see, as soon as I make too much suction, it bleeds from the bone. I just continue deeper and deeper and try to shape the groove, lateralize the groove, and test for elasticity. You see, I lateralize the groove. And then I test if it's plastic, and in this case it is, and I'm ready for the reinsertion. For the reinsertion, I use the standard portal, and I place a reabsorbable anchor, a push lock anchor, and it's loaded with vicryl tape. That means resorbable tape. But now it's not on the market anymore, so I have to use multiple reabsorbable sutures instead. So by having placed this anchor distal in the notch, I'm going to grab those sutures and bring them proximal. You see it here. And this is the first tape that I bring proximal. And then I'm going to put my first proximal anchor proximal. You see, this is proximal, and then I'm able to press the cartilage into the new formed trochlea. However, perhaps one suture is not enough, and therefore I place, I grab one more of the tapes and bring it proximal, and then I place the next anchor. In some cases I use 3 anchors proximal, and in some cases I only use 2 anchors. In this case I only use 2 anchors. So now the cartilage flake is reinserted. And this is basically the arthroscopic trochleoplasty. You see here, I think it's sufficient fixated, and I also, in some cases, I do a lateral release. Perhaps it would be better to do a lateral lengthening. I try to do a lateral lengthening, but this is just a suture that is left. I cut them out because they were not needed. And here you see, I try with my radio frequency device to cut the layers lateral in two separate, you can say, apart from each other, and thereby I somehow do the lengthening. This is the MPFL, and when you do a trochleoplasty, it's very important to test for the symmetry, because the point where you put goes a little distal. If you just use the normal, more proximal point, it will get tight inflection. So you have to test for the asymmetry. Good. So what are my indications? I mean, it's patellar instability. Sometimes they have only had one patellar dislocation, but they continue after physiotherapy to feel unstable. And they are very much impaired by this instability. So even though the patella do not get out twice, they are still very much trouble, and therefore I think trochleoplasty can be indicated. Naturally, they're also going to have severe trochlear dysplasia. In some rare cases, I've done trochleoplasty just for anterior knee pain. That is when there is too much bone in the proximal part of the knee, meaning they have a high ventral prominence. Then you can unload the patellofemoral joint with a trochleoplasty. They're also going to have a positive reverse dynamic patellar apprehension sign. And if you don't know that test, I think you should find this paper from Zimmerman. It's a very, very nice test because the patient feels very comfortable with this test, because you start inflection and you start to dislocate the patellar inflection, and the patient do not get apprehensive by that. And then you slowly straighten the knee more and more, and suddenly the patient starts to become apprehensive, and you measure the degree of the flexion, to which point the apprehension start. And basically you don't need to straighten the knee, because you know when the knee is straight, they will be extremely apprehensive. Another important thing for me is the lateral trochlear inclination angle, and if it's below 9 degrees, I will suggest a trochleoplasty. And then there's a positive J sign. It's not always possible, but nearly always. And just to show you a J sign here, you should try to see how huge forces there are involved in this. And that is the reason why you cannot just do an MPFL reconstruction, because an MPFL reconstruction is like a shoelace. It won't last forever. See this guy, I'm not able to keep the patella there. The forces are too high. This is just another example of a J sign. Good. So these patients, they are allowed full weight bearing, free range movement, and I never use a brace for any of my patellar stabilizing surgeries. And this is one-day surgery, meaning that they leave the hospital the same day. And this is just a protocol for the physiotherapists. You can find it on my webpage. So what is new on arthroscopic trochleoplasty? Yeah, basically we have just finished a study with 16 knees where we had pre and post-operative subjective scores, and we had the MRIs before, and we did the MRI post-operatively, and we measured on the 4 most proximal levels. And what we measured was the lateral trochlear inclination angle, the trochlear depth, trochlear symmetry, the anterior-posterior distance divided with the width, and the patellar tilt. And this is a new technique from Joseph. It's a two image technique. And basically what you do is that first you find the slice where the femur condyles are most prominent. And then I use this, you see on the picture on the right, I post it, put it on the screen, and then I scroll proximally until the most proximal slice where I notice cartilage on the lateral part of the trochlea. And then I make a line tangential to the trochlea. In this study, we found that preoperatively on the most proximal level, they had minus 0.4 degrees, and after surgery they had 10.3. So it's not completely normal, but it's better than preoperatively. And this is naturally average measures or mean measures. On level 3, it was 2.9 and goes to 13.9. So also better there. The trochlear depth, it went from 0.3 to 2.9, and from on level 3 to 1.9 to 4.7. And this is very close to normal. Trochlear symmetry at level 1 from 7% to 46%, and level 3, 32 to 49%, and this is normal. And in respect to the anterior-posterior distance, this is the anterior-posterior distance, this in the middle, and then divided to the width. And it is an expression of, is there too much bone in this area? Is the floor elevated? And what we found that level 1, it was 81%, and what is normal, it's here, it's 73% is normal. So 81, that's pretty high. And after the surgery, it went to 74, and on level 3, from 80 to 76. So this is us very close to normal. In respect to the patellar tilt, it went from 2.7 to 14.2. So that is also close to normal. And what, in my point of view, in most cases where you see patellar tilt, it is due to trochlear dysplasia, because the lateral facet of the patella articulate with the lateral facet of the trochlea. And when the trochlea has a low slope, so the patella automatically tilt. And when you deepen the trochlea, the patella suddenly goes into the trochlea again, and the tilt normalizes. So why do it arthroscopically instead of open? I mean, I started out many years to do it openly until a patient was really, really mad at me because she had so much pain after the surgery. And it forced me to think, can we do this arthroscopically? And then I had the chance to do some cadaver studies and figure out you could do it arthroscopically. But basically, there are no studies out there saying that arthroscopic is less painful than open, but we know that from experience it is so. So was my last open one. It was in 2007. And naturally, it gives a better spacious orientation compared to the arthroscopic. But the arthroscopic, I think you see more details when you do it arthroscopically. One of the problems with the open trochleoplasty is the risk of atrial fibrosis. And in this study, there was 11 out of 62 who needed further manipulation or arthroscopic removal of scar tissue formation, and you don't see that with the arthroscopic technique. So this is, in my point of view, the pros for the arthroscopic version. This is naturally minimal invasive surgery with less pain, smaller scar, less risk of atrial fibrosis, less risk of infection, and less risk of cartilage flap breakage, because I know from the open trochleoplasty surgeons they have experienced that the cartilage flap break during the surgery because the system sometimes pull too much and then it breaks. This is just to show you pre and post-operatively an example how the lateral trochlear inclination angle can improve. And for the latest study, this was a 5-year follow-up with the 16 knees, and the band score, which is the new PROM score, that more precisely tells how is the patient actually doing. And it went from 37 to 74, so good improvement. Today, I have to admit, I stopped counting several years ago, but it's at least above 150 arthroscopic deepening trochleoplasties, and I've had one redislocation. This was case number 7 many years ago when I started out, and I simply overlooked that that girl had severe femoral anteversion. And I had another one operated just for pain, and she also developed pain after some time after the trochleoplasty, and she also had increased femoral anteversion. I've had 3 DVTs, but no infection and no atrial fibrosis. And today, if people are above 30, I will use antithrombotic medicine. So this surgery has disseminated to other countries. I'm not sure if they do this in all of the countries, but I know at least they do it in Norway, Finland, and in Portugal and Israel. I'm not 100% sure with the other countries, but I think they do it there. And I wanted to show you a case, and I think this is a very typical case. This young girl, she had more than 100 patellar dislocations, started out when she was 10. She had, in the age of 16, a tibio-tubercle osteotomy, and then she had the screws removed and an arthroscopic synovectomy due to pain, but they didn't stabilize the patella. But when she was 23, they did MPFL reinsertion. And then when she was 23, she had a new arthroscopy. At that time, she had redislocated and had pain. And I saw her when she was 24, and I did an arthroscopic deepening trochleoplasty and MPFL reconstruction. So it's 10 years ago, and I know she's still doing very good. But this was preoperatively. She had a Kujala score 12, Techna score 0, band score 7%. She was in her bed, and you can see she could barely walk. This was her MRI. You see a convex trochlea, on the lateral X-ray, you see the classical things from the Tissure classification, TTCG 4 millimeter, and lateral trochlea inclination angle -4 degrees. And this was 14 weeks postoperatively. She had a very good physio, pressed her a lot, and I think it's amazing how she improved just by 14 weeks, thinking that she was lying in bed preoperatively. So a great success for her. And this was the postoperative results. See better Cordiola score, better thickness score, better BAM score. And this is just another example of a pre and postoperatively MRI. And this is how it looks. Basically, it doesn't. It looks nearly the same, but it is in this part of the knee where the big difference is that you don't see it by this image. You can see the bump is gone, but if you do an MRI, you will see that there will be a groove here. This are two. Just by occasion, I came up with these two MRIs from different part of the world. And that is some who have done arthroscopic trochleoplasty without being taught in the procedure. And I think it both looks awful. Here, that the lateral trochlear inclination angle is that there is no. And here, something definitely had gone wrong. I don't know how it looked before surgery, but it doesn't look nice. So I think you need to have the appropriate training before you start out. And naturally, I can be helpful if you need that. I regularly travel and teach surgeon either in cadavers or by patient. And yeah, just ask Artrex, because I have an agreement with Artrex. They help in these situations. This guy, he came from Hawaii to Denmark, and it's actually quite a long distance, so he didn't come to the follow-up. He sent me this 1 year after. So yeah, so that was basically it.